So I think we can start.
Yes. Hi, good evening, everybody. My regards from Istanbul. We are just starting as a new academic year with the webinar series. Today we have distinguished speaker from Budapest, Hungary, Dr. Attila Bokor. As you know, he is the member of our European Executive Board member. He is associate professor. He has MD and PhD. He is especially working about the endometriosis and deep endometriosis. He is, in fact, a gynecological surgeon, gynecologic surgeon. He is the real one. He is very busy about the deep endometriosis, especially colorectal surgery, more than 400 per year procedure in his unit. He is also the member of the ESHRE endometriosis guideline group. And today he will speak about the new, how can I say, not the technology, new way to extract the deep endometriosis specimen from the nodes. Thank you for joining us, Dr. Bokor, please.
Good evening, everyone. Thank you for joining us. And I would like to thank to Mr. President for his kind words. Actually, I think this initiation of Professor Oral, this webinar, I think it's a very important way of changing ideas during these pandemic years. So what I'm going to be talking about this evening is the use of nose procedures, the natural orifice specimen extraction procedures during the colorectal surgeries for deep endometriosis. I want to move on with my slides, but it's not possible. Okay, so let me try it again. Oh, perfect. So, as we know, for the conventional laparoscopic bowel resection, we need to perform mini laparotomy in order to extract the specimen and also to introduce the anvil from a circle stapler. Normally this is a very little tiny incision, like of 4 or 5 centimeters. So in general, the whole nose story, the whole nose philosophy is about to omit these 4 centimeters, which is ridiculous because who cares? I mean, it's 4 centimeters scar. I think nobody cares of a 4 centimeter scar on her belly, but I can show you somebody, I think she really cares about her belly and she really wants to omit this 4 centimeter scar. And this is the outline of my presentation that I will guide you through, and you will see at the end that this is not only about the look. So we have a number of benefits we can offer to our patients when we perform nose procedures. First of all, I would introduce you the nose technique. Then we move onwards on transvaginal and transrectal colectomies. I will give you a very short overview of a new article or a new study we have just published together with our friends, and I will show you some data about low anterior resection syndrome after nose procedures, and give you a very short overview of our prospective randomized controlled trial, the nose rest study, and we'll end up with some conclusions. So again, the nose stands for the natural orifice specimen extraction, which means that we omit this before mentioned little tiny laparotomy, and we use the vagina or the rectum in order to extract the specimen after colorectal surgeries. So we have a number of advantages. Obviously, there's no need for the laparotomy. Hence, the Richter's hernia chance is much lower. There is less abdominal pain after such surgeries, lower chance for post-op adhesion formation, obviously better aesthetical outcome, as you will see later on. And we think that shorter recovery time and these procedures can even lead to a quicker surgery. These are more specific advantages. As you see here, if after viscerotomy we find this plastic polyp, we can just remove it. Or also through the rectum or through the vagina, we can remove other specimens from previous surgeries, like as you see on this big cyst. Also nodules from the bladder and very limited segment of the bowel, which can be removed by nose techniques. So if we look at this very recent paper, here authors claim that the patient selection criteria are very ideal to our group of patients. As you see here, they say that an ideal patients for a nose surgery would be a non-obese woman with a BMI of less than 30, with a pathology involving the distal rectum and colon, and the maximum width of this specimen would be less than 6.5 centimeters. I think the majority of our patients fits very well into this criteria. If you look at this meta-analysis of Ma and co-workers, we can see that the duration of the hospital stay, the operation time, the time to first flatus, pain scores, and cosmetic results are all in favor of the nose procedures when compared to the conventional laparoscopic surgery. Here in the next slide shows the post-op complication rates, which are very important, I think. Here again, the complication rates were lower in the nose group when compared to the traditional way of laparoscopic bowel resections. The disease-free survival is not really applicable to our patients. And if you look at this more recent meta-analysis, again, we see that the surgical site infection, anastomotic leaks, and peri-op complication rates are less likely in the nose group when compared to the conventional laparoscopy. Intra-abdominal abscesses, more or less the same occurrence. The blood loss was again in favor of the nose procedures. Hospital stay pain scores are shorter in the nose group. Operation time, according to this meta-analysis, is a bit longer in the nose group when compared to the conventional laparoscopic group. In this recent prospective randomized trial, Zhu and co-workers, they randomly assigned 254 patients into two groups, nose group and conventional laparoscopy group. And they found that post-op complications were less likely in the nose group, and also the blood loss and post-op pain scores were lower. However, they reported a longer operation time in the nose group. The intestinal functional recovery again was shorter in the nose group. This is again very interesting randomized control trial from Belgium, from Albert Wolthuis's group. We see here that, interestingly, authors, they did not find any big differences between the nose and conventional laparoscopic colectomy group with regards of duration of surgery, the blood loss, and complication rates. However, here they report that the procedural costs are higher in the nose colectomy group when compared to the conventional laparoscopic colectomy group, which is very interesting. And I will show you some data on this because Voltheis's group, they use 2 endo-GIAs for these nose procedures, and I think one of them it's possible to spare and to reduce this very high amount of money they reported in their study. According to Albert Voltheis, the analgesia requirements were lower in the nose group, and this was the only significant difference between the nose group and conventional laparoscopic colectomy group. But if we want to use these outcomes to our patients with endometriosis, I think it's not very easy because you know these procedures were done on patients with colorectal carcinomas. Obviously, we cannot implement these outcomes like automatically to endometriosis patients. As you see, the different age of these patients, it's very evident, and also the nutrition status of our patients are far away, like different than those patients with bowel carcinomas. If we go back again for the cosmetic outcome, we see that patients after nose colectomies were more satisfied with their cosmetic outcome. If we look at this body image scale, cosmetic scale, or body image questionnaire, in every item, the nose colectomy was superior to the conventional laparoscopic colectomy. So as we see here, colorectal surgeons are very keen on doing laparoscopic surgeries, and regarding the colorectal cancer, and also administer the nose procedures. We can observe a steady increase in the nose procedures throughout these last years. But according to this table, again from the Albert Voltheis's group, there are only very few groups active in the field of endometriosis. Majority of the authors, they report case series dealing with colorectal carcinomas and other bowel diseases. Endometriosis is very seldomly reported. Only Voltheis and co-workers, Mauricio Abrao and Getzi, had very limited case series dealing with patients with endometriosis. From this article of the Leuven group, we can see that the first transvaginal specimen extraction was performed by Redwine, and again, the first transrectal specimen extraction was performed also by the same author in the early 90s. However, it was a very limited number of cases, like 1 or 5 cases. This is an original technique which was proposed by Albert Voltheis. During this technique, as you see here, it is possible to extract the specimen, also to introduce the anvil through the rectum. But as you see, the steps of this procedure, the surgeons, they use 2 times endo-GIAs and 1 circular stapler. According to our philosophy and our technique, it is possible to spare one of these endo-GIAs. I will show you later on in a video. So we have also published our first series 2 years ago, and here we found a statistically significant difference between the nose group when compared to the conventional laparoscopy group with regards of the duration of the surgeries and also the mean hospital stay. The rest of the outcomes were very similar. If you look at the complication rates here, again, we did not find any difference between the two groups. So, as you see, the nose colectomy is as safe as the conventional laparoscopy and has some benefits to our patients. If we come up to the technical questions, here I brought you two videos, very short ones. On the left-hand side, you can see a transvaginal nose colectomy, and on the right-hand side, you can see a pull-through technique, which was initially introduced by Redwine and co-workers. So you see, it is possible to extract the specimen either through the anus or through the vagina. However, we would never recommend to do colpotomy only for specimen extraction, because in my opinion, it's really increases the chance of rectovaginal fistula formation, and we would only do transvaginal specimen extraction when the vagina was already open because of vaginal vault resection. Otherwise, we would never do transvaginal specimen extraction. We always go for transrectal or transanal specimen extraction. Here's the video. I promised you, you see, this is the technique we use in our daily routine. So we mobilize the rectum. As you see, the rectum, actually the nodule is tied up. We have two ligatures, one is distal and one is proximal to the nodule. We always use a traumatic bowel clamp in order to decrease the fecal spilling. Here you can see the viscerotomy. Now we open the bowel. As you see, this is a very limited resection. We only mobilized this affected segment of the bowel. This is what we call a tubular resection. There's no need to a big lateral mobilization of the rectum. Here we use specimen bag. We put the specimen into this bag, and now this is the nose moment. We introduce the anvil. We use a camera bag again in order to decrease the chance of the fecal spilling. As you see here, we just are able to take out the anvil, and now this is the extraction moment. So we extract the specimen through the rectum. And from now onwards, the whole procedure is very similar to the conventional laparoscopies. As you see, we just close the rectal stump, and we only use one single endo-GIA. Therefore, I think this is also a very economic procedure, so there's no need for other endo-GIAs because we always perform a hand-sewn first-ring suture in order to fix the anvil to the proximal part of the bowel. Again, this is a very simple procedure. Now we remove the clamp from the proximal part and create the anastomosis as we do during the normal or conventional laparoscopic bowel resections. So again, only very limited segment was mobilized, and I think This is one of the major differences between the conventional and nose procedures. And also, again, we are able to omit the laparotomy in order to extract the specimen. So if we go very close to the bowel wall, we are able to preserve the autonomic innervation of the pelvis and also the bladder, rectum, vagina. And we call these procedures nerve and vessel sparing procedures because this is just a benign condition and we have to stick always to the bowel wall and resect as less as possible during these operations. Just to not to get you bored, you will see here video I brought you when we further increase the safety of our procedures. You see we use an ICG angiography in order to assess the rectal perfusion after anastomosis. You see this is end-to-end anastomosis of the rectum. We are performing here a nose procedure and we are able a real-time assessment of the rectal perfusion. Obviously, robotic surgery is also possible during nose procedures. If you want to check this video, it's possible. I was actually watching it. It's only 4 hours, so if you have some time, please go on this website and follow this video. Very shortly, we have assessed the LARS, the low anterior resection syndrome, among our patients from three different centers, from Bordeaux, Horace Roman, from Vienna, to the list in our centers. We assessed the LARS incidence among patients with colorectal resections and also patients after disc resections, namely the Juan technique resections. We found, as you will see, not really big differences with regards of LARS. Disc resection was not safer. It offered a minimum difference regarding the LARS, and this difference was not statistically significant. So I have performed a sub-analysis of our data, and we checked whether nose procedure is associated with a lower LARS scores, and I was surprised that it is definitely. So after nose surgery, the LARS scores were a bit lower, and this difference was significant according to these data. In the near future, we will face a big change in assessment of the LARS. As you know, LARS can be assessed by a validated questionnaire. It's very simple tool. It contains only 5 questions, and after assessment of this questionnaire, we can state a diagnosis of the low anterior resection syndrome. But in the near future, according to this position statement, the low anterior resection syndrome will be much more easier to diagnose. And also, in my opinion, this will lead to a huge increase of the LARS patients among our cohort of patients. You see, according to this article, if a patient has at least one of these symptoms leading one of these consequences in blue, we can state the diagnosis of the low anterior resection syndrome. And I'm afraid that we have to face huge increase in the occurrence of the LARS in the near future. And last but not least, we would like to answer some open questions. Namely, is it, this whole nose philosophy, is it a real big difference among patients operated with endometriosis? And therefore, we have conducted a prospective randomized study at our department with a large sample size, almost 280 patients. This study ended in September this year. This is a prospective and randomized trial with a simple randomization. And we used online questionnaires in order to assess the quality of life of our patients and also fertility outcomes. Patients were asked to fill a questionnaire at the time of admission and follow up at 30 days, 6 months, 1 year, and 2 years after the procedures. As you see here, we used quite a number of questionnaires, and we are very keen on the final results. So I hope that I can let you know in the near future what's going on with the nose procedures among patients with endometriosis. To end up with some conclusion, as you have seen, the patient selection criteria for nose colectomy, I think it's ideal for our patients with deep endometriosis of the rectum. The nose colectomy is as safe as the conventional segmental resection and offers a number of benefits for our patients, namely shorter hospital stay, lower postoperative pain, and better cosmetic results. So I think this is a good technique, and we can use in the treatment of the colorectal endometriosis of our patients. Thank you for your attention, and you are very welcome to follow our webinars. You will see we're going to have big names coming. Horace Roman next month, showing also in November, Ertan Saridogan this year, December. So the big authorities of the fields will join us. So please follow our webinars. Thank you for your attention.
Thank you, Dr. Bokor, for the fantastic lecture. Thank you so much. Actually, do we have any question for the lecture to Dr. Bokor?
Dr. Oral, I have a question.
Please.
Hi, Attila. This is Taner Usta from Istanbul. Thank you about
How are you?
presentation. It's nice to see your presentation. I'm wondering if the patient have a high-level lesion, which is on the sigmoid region. Do you face any problem to take it down, or do you have any difficulties when the lesion is located on the upper area?
Taner, this is a very good question, and this is quite a technical difficulty. So we use laparoscopic instruments because they are long enough to grab the specimen and to extract through the anus. And actually, the introducing of the anvil is not always very easy, but it's possible. But I agree with you, the higher up nodules are not always easy to extract using the nose procedures.
And the other question is, if you face a double lesions or multiple lesions, do you change your way?
No, because the whole resection is the same story. So we go for this tubular resection, including all the lesions. And after we do the segmental resection, in most of the time, we are able to extract the specimen through the rectum or anus, depending on the height of the viscerotomy. And also, we are able to introduce the anvil into the pelvis. So this is not a big difference.
Okay, thank you, Attila.
Dr. Bokor, we have question from Istanbul, Dr. Cihan Kaya. He is asking, is there any limit for the size of the nodule? Since you only mobilize a small part of the bowel, what about for larger resections? The first one. And the second one, what about the contamination risk if you compare with the conventional laparoscopic colon resection?
Okay, both are very, very valid questions. Regarding the size of the nodule, we never had any difficulties. So we can extract 5 to 6 centimeter large nodule, as you have seen in this article of the Albert Wolthuis group again. And regarding the contamination, this is again a problem. So therefore, we administer this clamp to decrease the chance of fecal spilling. Also, we always use a camera bag during the introduction of the anvil. After the procedure is done, we always do an extensive lavage. According to the literature, there are higher CRP levels after nose colectomies when compared to the conventional ones. However, this difference is not significant. We never experienced higher complication rates or higher pelvic abscess rate among our patients.
What do you mean the higher CRP levels?
It's after our procedures, the CRPs, the day after, the first post-op day are around 100 and steadily decreases at the third day of the post-op period.
For the usual one, right? There is no complication.
Yep.
Just because of the procedure, right?
Yep.
Thank you. Any question from audience?
I have a question. First of all, I'd like to congratulate Dr. Bokor for the presentation. And I'm very happy that he's advocating for the nose procedures. In our clinic, we don't perform any conventional procedure for more than 2 years. And I think the appearance is of paramount importance for the patients. And this is definitely something we cannot neglect, even if it's 4 or 5 centimeter scar. My question was regarding the cost, because this is something you wanted to comment in the first place.
Yes, indeed. So the cost, like 2,500 euros roughly, suggested by Albert Wolthuis and co-workers, I think far higher than we have here in Hungary. Obviously, the healthcare prices, it's not comparable to Belgium in one hand, and in the other hand, during our procedure, we are able to spare one of the endo-GIAs by using this hand-sewn knot, like purse string suture, in order to fix the anvil in the proximal part of the rectum. That's why our prices are similar to those of conventional laparoscopic bowel resections.
Thank you. I have one more question. Do you perform any bowel preparation, and what kind of antibiotics get the patients during the surgery, after the surgery?
Yes, this is also a very good question, Alan. Thank you. We do mechanical bowel preparation the day before of the surgery, or we always, on the table, we always wash out the rectum before the nose surgeries, and we always administer cephalosporin and metronidazole for the nose patients. Like we do it the day before the surgery, and we administer it 48 hours after the procedure.
Okay, thank you very much.
You're welcome.
Dr. Bokor, Dr. Jan Dronowski from the Prague is saying congratulations for you for your techniques. He is so impressed about your techniques. He say thanks for the lecture. Jan Dronowski from the Prague.
Okay, thank you. I will send an email to Jan.
Any question from the audience? What is your rectovaginal fistula rate after this procedure? If you compare with the conventional one, is it the same? Is it decreased or is it increased?
It's the same, completely the same, and it's below 2%. So we got lucky with this randomization. So in the past, when we started 10 years ago in Hungary, these surgeries, we had around 4% of rectovaginal fistulas and anastomotic leaks altogether, I mean. And now we ended up with 1.8, 1.9% altogether. So obviously there is still room for improvements, but this is a low chance for the rectovaginal fistula formation, I think.
Another question. Another question from again, Dr. Kaya. He is asking, do you have any data about postoperative natural functions, such as urinary functions or sexual functions? Is there any difference between the conventional one?
I think this is also a very interesting question, and we are dealing with these issues in our randomized trial. So I really hope that I can answer these questions within like at most 3 months. So please, I will get you informed, okay? So at the moment, we have no data on that.
Dr. Bokor, we know this procedure lasts 10 years, right?
Yes.
Yes, but it's not so popular. In my country, just a few, 3 or 4 surgeons is dealing with this procedure, not too much. We have good surgeons, but they are not interested in this procedure. And at the world and Europe, only a few centers is dealing with this procedure. What is the reason? Why it's not so popular?
Actually, this is also a very good question. Thank you. So as you have seen, colorectal surgeons, they really are keen on doing nose procedures. So they really want to decrease the trauma to the abdomen, because we all know that this makes sense and lowers the pain scores after surgeries, also offers better aesthetic outcomes. Maybe gynecologists, they're not really interested in these procedures. I cannot give you the answer. Yes, interesting. I know that in Belgium, in the multidisciplinary team of Albert Woldhuis, they still do a lot of nose procedures. As Anin said, with Professor Tinneberg, they also do. But the rest, I'm not aware of any other groups doing a lot of nose procedures. No, this is just pure surgical philosophy. I just cannot give you the answer.
Any other question?
I have Dr. Oral, I have a question. Can I ask a question to the Dr. Bokor?
Please.
Thank you very much for your nice presentation. The vaginal way is another natural orifice way to take out the specimen. Why don't you prefer to vaginal way? For example, between the sacrouterine ligaments, you can cut transversely and you can take the specimen inside from the outside. Why especially do you use rectum to take out the specimen? Vaginal way is another way, natural orifice way. Thank you very much.
Thank you very much, and I fully agree with you. Thank you. This is a valid comment again. So we can always use a colpotomy when the bowel is not opened. So you can remove your specimen to the vagina, rectum, whatever, when you do not perform bowel surgery. If you also open your rectum and the vagina is not open because the vaginal wall is intact, and you go for phlebotomy only for specimen extraction, in my opinion, in this way, you will increase the chance of rectovaginal fistula formation. That's why we never, ever do phlebotomy only for specimen extraction itself. So when the vagina is already opened because of big vaginal nodule, obviously it is possible to extract the specimen through the vagina. There's no problem.
Dr. Bokor, if the vagina is, if you make an incision is wide enough, maybe it is possible to occurrence of a rectovaginal fistula. But if you don't make a large incision to the vagina, maybe the rectovaginal fistula rate maybe will not be so high as you expected.
Okay, though if we look at the data from the literature, the problem is that if you have your vagina open and your rectum open as well, this is the only circumstance practically which will increase your rectovaginal fistula rates. So in my opinion, if you are able to omit the vaginal incision, I think it's wise to do so, because otherwise you will end up with a serious complication. But if you have already opened your vagina, no problem. You can remove your specimen, and I think it's also a nice technique to do.
I have one more question. Whenever you have to do a partial colpectomy and a rectal resection, for example, for diabolo-like nodules,
okay,
do you perform standard diverting ileostomy and or place an omentum plumb between the two sutures?
What we do that we never perform ileostomies. Among this series of 280 patients, we did one single protective stomas. What we do that we use mesorectal flaps. So in the past we started with omental flaps as interposits, but we found this a bit too big procedure, very demanding, and also sometimes led to different types of ileus. So now we perform routinely mesorectal flaps. And also, if we look at the series of Horace Roman, we see that the protective stomas, they don't really decrease the rectovaginal fistula rates. They only decrease the severity of the fistulas. And in our daily routine, we never do any protective stomas.
Thank you. I think there's another question from Dr. Drachanovsky. Dr. Oral, you have to unmute yourself. I'll do that. Okay.
Do you hear me? Okay, thank you. There is a question from Dr. Jan Drachanovsky from Prague again. He is asking, would it be also possible to put the tobacco stitch on the distal part of the bowel in the same way as on the proximal part in order to spare the EEL?
Yes, I've seen, thank you for your comment, Jan. And I've seen your technique in Prague at our conference. So I was really delighted. So I think it's a brilliant technique. It's cheap, safe, very nice, very elegant. So this is the way we do, but as I told you, there is always room to some improvements. So maybe in the future we can switch to your techniques. And I really enjoyed the technique you used at your video.